Okay, welcome to this summer's course, Communication Disorders in Infants and Toddlers, SBA 521. I'm Dr. Rachel Powell, and I'll be teaching this course to you this semester. I'm trying something a little different with the video camera to see my face. Maybe that would help with the interactions, make me feel like I'm really there. So I'm going to see how I like this and for this session, and we may or may use this throughout the summer. So let's get started. All right, so semester outline. Your textbook is Language Disorders from Infancy Through Adolescence by Rhea Paul and Courtney Norbury. And I misspelled Paul. All right, you will have weekly assigned readings as they are outlined in the syllabus. You'll have weekly discussion responses that are required. You cannot miss more than 2 required discussion responses without dropping a grade. That is in the syllabus, and you can see that. And if you have any questions, please let me know. You will have 2 exams, 1 group assignment, another assessment project, but this time for preschool assessment. Rather, the one we did previous semester was for children language assessments. So this is going to be a birth to 3 assessment project that you'll participate in with a group. And then 1 individual project, which will be a research critique. You're going to be assigned a research article regarding early childhood. It might be interventions, it might be assessments, but you're going to be required to read that research and review it. So here are your group assignments for the assessment projects. We have Sarah, Glenn, and Hannah for the CSB-SDP, Georgia and Megan for the Rossetti. Group 3, CDI, both forms for Whitney and Rebecca. Group 4 is the Real 3, Victoria and Melissa. Bailey scales for Mallory and Megan. And Group 5 and Group 6 is the DP2 with Amelia and Mallory. The way this course is set up, I've set it up in modules, so we'll discuss 8 modules over the 8-week course period. Module 1, which is this module right here, is Early Intervention, or EI for short, in speech-language pathology, as well as premature and high-risk infants. Module 2 is Oral motor and feeding issues, vocal and phonological development. Module 3 is Cognition, play, and gestures. Module 4, Semantics and syntax, communicative intentions. Module 5, Special populations. Module 6, Autism. Module 7, Putting the pieces together, assessment and outcomes. And finally, Module 8, Putting the pieces together, intervention techniques and evidence-based practice. So let's launch right into EI and speech-language pathology. So guiding principles. You were assigned an article by Paul and Roth in 2011 regarding the guiding principles of early intervention services. So in that article, it discusses 4 separate areas. Number 1, services are family-centered and culturally and linguistically responsive. Number 2, services are developmentally supportive and promote children's participation in their natural environments, and we'll discuss what is considered a natural environment. Number 3, services are comprehensive, coordinated, and team-based. And finally, number 4, services are based on the highest quality evidence available. And as you've learned in previous semesters, that's regarding evidence-based practice. So, principle 1, family-centered practice. What exactly does that mean? So, family-centered means the family is the primary recipient of services. If you look at this in comparison to school-based services, the child is the primary recipient of the service. But in early intervention service, the family is the primary recipient of the service with their infant or toddler that you're working with. You should have individualized intervention services based on the concerns, preferences, priorities, and resources of the family and child. So the family's resources might indicate what kind of support they need. Less resources might indicate more support. More resources might indicate less support. It's very highly individualized depending on what your circumstances are within the family. So therefore, it's a continuum of options based on individual preferences, needs, and resources. And sometimes families might opt out of having less support and if they feel like they have the resources that are necessary, particularly within this role in early intervention. We're going to be discussing a lot about the role in the NICU services and when children come home from the hospital and very early in development. And a lot of those services and supports are in the area of counseling these parents and these families about the different strategies on how we interact with children and help grow that language and those pre-linguistic skills. So what does it mean to be culturally and linguistically responsive to services? Well, SLPs need to recognize their own cultural values, so what you're bringing to the table as an SLP, as well as the families, with an understanding of variances and beliefs within cultures. So even if you have 2 African American families, they might not have the same values across families. So we not only need to recognize our value system that we bring as an SLP, or the value system at the family and whatever their culture is, but the variances within their cultures. And this is commonly referred to as cultural sensitivity. And I know you recall talking about test sensitivity and specificity. It's along the same lines, how sensitive we are to the needs of the families and their cultural preferences. All right, so this indicates there could be variances in their culture and their values about learning. Some families might place a higher value on learning than others, depending on what their cultural backgrounds are. This responsiveness can be in regards to their beliefs and perceptions about adult-child roles in the family. You know, there's sometimes children are perceived to be seen and not heard, so that can be a barrier in developing their language if these are children that need to be interacted with and have interactions with the adults. And so sometimes it's the training with the families about what is necessary to grow their children. There are expectations for child behavior at different developmental levels, and sometimes we have to counsel parents about what the children are doing, although they might be a certain age. In comparison to their cognitive and linguistic ability is developmentally appropriate. So what behaviors are okay for a, say, 6-month-old or 1-year-old if the child's functioning on a lower level because of these prematurity or high-risk factors, their delayed development. How do we help parents understand what the expectations are on the developmental level, not only their chronological age, and also on their gestational age? So again, a child who's born at 24 weeks or 30 weeks is not going to be at the same levels as a child who was born full term, and we'll discuss that further into the semester. Sometimes you'll have a culturally different family perceptions, attitudes towards disability. Some families are much more accepting of disabilities than others, and we have to think even in the last 50 or 60 years how perceptions towards disabilities have changed across the United States alone, much less across cultures. And so we may need to work closely with interpreters and translators or a cultural linguistic mediator when we're working with these families. So an interpreter or a translator would, of course, be interpreting or translating into the family's natural language. The cultural linguistic mediator, however, is someone who helps not only with translations, but that cross-cultural factor of how what we want them to accomplish as a family is achieved within their cultural sensitivity values. And sometimes that cultural linguistic mediator might be the primary service provider or the service coordinator. That could be a role that's assigned through the IFSP, which is the Individualized Family Service Plan. You may recall that from last semester. We'll get into that in a few slides. Okay, so services in a natural environment. We offer developmentally supportive services. What does that mean? The foundation includes SLP's knowledge of typical communication, speech, language, and emergent literacy development. So you've spent a lot of time learning about what is typical development versus atypical development. And that's because when you get in and get ready to diagnose a delay or a disorder, you need to know how it is in comparison to what we expect most children to be achieving by certain ages. So the SLP's knowledge of typical development is very critical. The SLP also needs to have an awareness of the pivotal role of quality adult-child interactions and variations in a nurturing home language environment. Okay? Okay, so we need to have an awareness of our role in enhancing the quality adult-child interactions and how we need to be culturally sensitive to what's happening within those environments, but also how to engage those parents without crossing that boundary of thinking that we're critiquing the parents or criticizing them, because we're having a rapport with the parents. It's going to be very, very crucial. We also will provide services geared toward the family and child's age, cognitive level, learning style, strengths, and interests. So taking all those factors into consideration. So that's how we offer the developmentally supportive services. Now, within the natural environment, participation in natural environments, that's where service should occur is in a natural context. Federal guidelines require services to be provided in natural environment to the extent possible. If it cannot be provided in the natural environment, you need a justification as to why not. But a natural environment could be a hospital setting. It could be a preschool setting. It could be the home environment. The critical thing here is that even if you're providing a service for EI within a clinical setting, say they're going to the SLP office, The natural context is the implication that the family is involved in interacting with that child with you as the clinical service provider as well. This is not happening in isolation with you removed in the clinic room and the family in the outside room waiting for you to finish therapy. The family is very much involved in this process. Some things that you can do to be in the natural environment and observe the natural environment, observe the daily routines, the bedtime, feeding time, bath time, all these things that you do as part of a natural routine within a child's environment. If you're observing that, you can see those adult-child interactions and see the areas in which we might offer services to help improve those pre-linguistic skills in these children. So find out familiarity with the daily routines, observe the interactions, and embed the interventions across the natural settings and interactions. And we talked a lot about this last semester with the scaffolding parents and teaching parents how to scaffold their children. Family-centered services may or may not involve the parents depending on individual families. So what if you have a child that's being raised by a grandmother? So the natural context, the natural setting involves that grandparent and not the parent. So it really varies child by child. All right, so comprehensive coordinated team-based services. Comprehensive services means that all domains of development are interdependent during early childhood, warranting comprehensive services, service coordination, and access to supports and resources. We cannot separate cognition from language or gross motor from fine motor. They're all working together. So all domains, the domains we're typically looking at are cognition, communication or language, motor skills, social emotional skills, and adaptive skills. And adaptive skills would be how, of course, feeding, toileting, those come into play later. But those are the 5 areas of development that we're typically assessing of how those children are performing in that environment, and then also how the families are interacting with them. So comprehensive services address all those specific areas. Coordinated services are integration of services that should be clearly articulated with the IFSP. So you have to designate a service coordinator. The service coordination could be a primary service or a collaborative team approach with communication amongst all team members, and that needs to be decided within the development of the IFSP. So we have different types of team-based services. It includes the family and all professionals involved. It might be the SLP, the occupational therapist, the physical therapist, a special education teacher, could be a physician, could be a nurse, anybody that's pertinent to that child's environment, that life, the preschool teacher, or the daycare worker that has that child while the parents are working. So there are 3 different types of teams they discuss. Multidisciplinary team, children are seen separately by professionals from different disciplines. Integration is left to the service coordinator, and services, the downside of this is that services can be fragmented. So SLP works with the family and the child individually. PT works with the child and the family individually, and there never is necessarily a meeting where the SLP and the PT and the family all sit down together about the services that are being provided. So there are lots of cons with multidisciplinary team approach. And really, the other 2 types of team approaches are what's promoted within IFSP best practices and from ASHA. An interdisciplinary team is where professionals can assess independently or as a team, but the team members share goal setting and implementation of services. So I might do my SLP assessment, the PT might do their assessment. We come together after our assessments are complete to write goals that are in coordination with each other and provide the service with the SLP and the PT together with the family. Then we have the transdisciplinary team where there's the flexibility and roles of team members. So the SLP might help with addressing some of those physical goals. The PT might help addressing some of those language goals. It offers consistent interaction, communication, and coordination of planning, assessment, and intervention. And ideally, transdisciplinary team is the type of team approach you want. ASHA has promotion of this approach across all environments. They're calling it IPP, interprofessional practice, and IPE, interprofessional education. So if you just Google interprofessional practice or interprofessional education on ASHA's website, you can get a lot of information. They have a webinar regarding the specific type of practice, and it just talks about how important it is for everybody on the team working together, including those physicians, those nurses, and the service providers with the family, so that those receivers of our services get the best benefits of our interactions with each other. But we know this can be challenging with an actual service provision, but that when you operate environments that aren't conducive to transdisciplinary teams or interprofessional practice. I think the best settings for this type of team approach, I have all of those disciplines within one setting. For instance, the Children's Center for Communication Disorders at USM, I know is one place that is an exemplar when it comes to transdisciplinary team because they have OTs, PTs, special ed teachers, SLPs on staff, and the families are there with the children when they're receiving the services. So it really is an ideal transdisciplinary team approach because everyone's working with that child together. But that's not always happening in the real world. So most of the time you're seeing more interdisciplinary team where people are functioning independently. They can work together, but they have periodic scheduled discussions regarding that specific child and the services being provided. All right. And then finally, evidence-based practice. Evidence-based practices are informed by current high-quality scientific research that's usually considered published in peer-reviewed journals, the SLP's expertise and experience, and then the family and caregiver preferences, values, and interests. So your expertise in SLP, your experience as an SLP carries as much weight and value as the family or caregiver's values. So that's very important to keep in mind, and that we're not operating just in isolation with the research. This is what the research says. We're bringing our expertise and our knowledge into that to how to apply that research into praxis. So external evidence is that peer-reviewed journal, the research findings. Internal evidence includes policy, informed clinical opinion, professional and consumer values, and perspectives and professional consensus. So that was the gist of the Paul and Roth article. Now we're going to move on to the information covered in Chapter 6 of the Paul book, Language Disorders from Infancy through Adolescence. So early intervention and speech-language pathology regulations. Again, this is family-centered practice. The family is the center of the services being provided. And that's because the burden of care for fostering infant communication development falls on the parents, which may already be stressed from the experiences of having a child with special needs. If they are identified, say, at birth, that means that child was born prematurely or had an identified disability either prior to birth or when they were born. And it can be very overwhelming. I think the two articles, Welcome to Holland and the interview with Holland about how that parent felt. You know, you're going to Minnesota or Illinois, or I forgot what the state she's going to, and all of a sudden, no, you're in Holland. This is not what they're experiencing as a parent. And I can say as a parent of a newborn who's 6 months now that it's overwhelming enough to have a child when you're coming home from the hospital, and especially that first child. And then if you have a child with a disability who has all these needs, those parents can be experiencing a lot of stress, particularly if these children were medically fragile and they didn't necessarily know if they were even going to leave the hospital, much less leave the hospital with services to help enhance their development. So this can be a lot to take in for those parents. So the practice and therapy not only focuses on these infants, but also on the needs of the family. Public Law 99457, Part H, established the Early Intervention Services Program in 1986. So this has been around for about 30 years. Well, in fact, that looks like this is the 30-year anniversary this year. And in 1997, with the revision of the Individuals with Disabilities Education Act, or IDEA for short, they moved the early intervention services from that Public Law Part H to IDEA, and that's Part C. So it's a Part C to Part B transition is what we call it now, and that Part B covers services within schools. Part C covers early intervention services. Now, what Part C of IDEA requires is an individualized family service plan, or IFSP for short, for children birth to age 3. This focuses on the child in the context of the family and includes information about the family's resources, priorities, and concerns, and may include some services for the family. So the services might be counseling. It might be services for just general infant care. It varies depending on what the family needs and the family's knowledge and resources. But the services should maximize the development of the child and optimize the family's capacity to address the child's needs. So the requirements of IFSPs by law, there are, I believe, 8 requirements. And number one, information about the child's present levels of physical, cognitive, social, emotional, communicative, and adaptive development. So again, I talked about that earlier about what those developmental levels we're looking at, and those are the areas that we're considering. You need a statement of the family's resources, priorities, and concerns related to enhancing the development of the child. So what are your concerns as a parent? If it was my child, I would say, oh, I'm concerned about his interaction skills, his eye gaze, because I'm an SLP and that's what I'm looking for. Um, but it would be what the family wants for their child, the enhancement of those services. Number three, statement of the major outcomes expected to be achieved for the child and family, and the criteria, procedures, and timelines used to determine progress and whether modifications or revisions are necessary. Basically, you have to have goals, your major outcomes goals, what you want to achieve. So what's your criteria for achieving that? What's the procedure and the timeline? So that's similar to the IEP SMART goals that we've discussed. In 6 weeks and 9 weeks, the child will do this with this percent accuracy. And I know when y'all did y'all's treatment plans last semester, I really emphasized making those goals attainable and achievable because that's what's required as part of the law. That these parents understand what we're trying to achieve and that we have that criteria for achievement so we can know when to move on to the next area of goals and objectives. Number four, statement of the specific early intervention services necessary to meet the needs of the child and family, including frequency, intensity, and method of service delivery. So is this going to be 30 minutes, 2 times a week in the home, individualized, 30 minutes, 2 times a week at the clinic setting with a team of PT and OT services, 30 minutes, 2 times a week within the NICU environment, 15 minutes, 20 minutes, whatever it is. That's where this is stated. And the environment service is provided in justification if not in child's natural environment. So either it's provided in the hospital and you state that that's the child's natural environment, or it's provided in the home, or if you're providing it in the clinic, which is not the child's natural environment, but your justification as to why. And I think the Paul and Roth article had some great examples about what those individual components of this law meant when you read that article in preparation for this week's lesson. Number five, list of other services such as medical and other services and funding sources to be used. So any other service that's going to be used, and where's that funding going to come from? Is it EI funding, or is it going to be funded by Medicaid, reimbursement, variations in that? 6, projected dates for initiation of the services and duration of services. So the services will begin October 1st and they will go until December 2nd of 2016. Name and discipline of the service coordinator responsible for implementation. So every IFSP has to have a service coordinator. It may or may not be the SLP, depending on the type of EI structure that you have. And then finally, a plan for transition to preschool services. So even that's part of the requirement that, especially when they're 2 years old and they're going to be transitioning to the school plan, you have to have the plan for transition of the services for the school to pick up that child to continue that service so you don't have a drop in services. And as a school, we're required to pick up those children by the age of 3. So there is no lull in services or a time where the services are not received for those students. So there is no official form or format approved for IFSPs, nationally speaking. I'm not familiar enough to know whether or not the state has a specific IFSP form in Mississippi. But you know, that is similar to IEPs. There's no specific form for IEPs set by the federal laws. It's individualized based on the states. So I would say it's probably similar in Mississippi, but as long as you have those specific requirements, you're within compliance of the law. Now, some children are identified at birth and some are found through child find. And so child find services are you have to make concentrated efforts of educating parents and professionals in what is developmentally appropriate for children and when to make a referral to an SLP or in other areas of PT or OT if the child's not developing in the timely manner that we expect them to. So we might have conversations with the pediatricians and the local clinics about what is age-appropriate language skills. I do a lot of promoting with Better Hearing and Speech Month and with individual parents. And I even use Facebook as a platform for that. This is what children are expected to be doing. Ash just put out the Identify the Signs campaign, which has been a really great resource to use for child fund. I'll post a link to that within the module so you can watch that and be familiar with efforts ASHA is making to help identify these children earlier, because I can tell you firsthand that we have every year children who show up to school at age 5 who've never received services because they weren't aware the services were there from the school at age 3, much less you could have services from birth. So that's unfortunate, but it's just the world we live in, particularly in rural areas where you have a high population of individuals living in poverty or below the poverty line, and they just may not be getting those childhood services that are available to them or accessing them. Even if they can access them for free, they just may not have the knowledge to do it, or culturally not have the means to do it. So it's a challenge, and we just continue to face it piece by piece, and I'm thankful that ASHA has identified that as an area of concern, nationally speaking. So how do we identify them at birth? Who are these high-risk infants? Of course, we can use standardized instruments that are available for identifying deficits in pre-linguistic children, but a standardized instrument needs to be supplemented, and all of those psychometric testing properties that we've talked about, all that test sensitivity, specificity, all of that needs to be taken into consideration when we're using assessments to identify these children, particularly pre-linguistic children, because there's such little signs that we're looking for linguistic interaction. But I know I had a baby come into an IEP meeting, and I was comparing her to my child, and she was 4 months and he's 6 months. This was very recently, and the child was premature, and she was very, very small. And I was trying to get some interactions with her, some eye contact, some joint attention, seeing if she would smile to me. And there wasn't enough of a true delay to say, hey, you need to get her checked out, because it's so variable amongst children within that age. But I could already see signs of that child not having that same communicative intent and interactions that my James has or had at 4 months old. At 4 months old, he was a very interactive child. He would look at him, he smiles. It didn't matter if it was a stranger or a familiar person. He just had that joint attention already. So that's something that U.S. SLPs need to be aware of. How are we identifying those children very, very, very early on with such minimal observable behaviors that they have that are pre-linguistic? So the caregivers are significant partners in assessment. We need to be relying on those caregivers to give us information about their child. And then we also need to use observations, because those are valid methods of measurement and observing across the environment, across those parent-child interactions. So language disorders are the most common developmental problem that presents in preschool, according to ASHA. And that's not surprising. In fact, in school-age children, language disorders, speech and language disorders, are the most common special education eligibility up to 4th grade, up to age 9. And then it switches to SLD. So most of the children that are identified at this age are identified because of our field for the speech and language interventions and needs. So work with high-risk infants is preventative intervention. This is not, we're trying to prevent them from having that service later on. They can have feeding problems, they can have hearing loss, and they can have neurological and behavioral deficits that have been identified. This assessment, identification, and treatment must be a team effort, including the parents. It's very critical that we include the parents or caregiver of that child within this assessment process. So what is a high-risk infant? Any condition that places a child's general development in jeopardy also constitutes a risk for a language development. So automatically, if they're born premature, and we know that's a potential risk in their general development, therefore they're at risk for language problems. And I've known several people, friends, associates, whomever, who've had children that were premature. And I remember having conversations with them about the conversations that were had with them in the hospital setting, and saying, okay, she was born at 32 weeks gestation, so she had to stay on the NICU for 4 weeks. This is what you're going to be looking for with development, and right now we're discharging her. She looks great, but you need to be watching that her language develops in an expected matter of time, and that her speech is clear. And parents, there was a lot of counseling with the parents done within that setting when those children are born very early, and that's part of those EI services. The March and Dines estimates that 12% of newborns can be considered high risk. So that's 12% of those premature babies, and in addition to the ones that have those prenatal conditions that are already established. So what are some prenatal factors? Maternal consumption of alcohol, which can lead to fetal alcohol syndrome, drug abuse, which would also be a syndrome, usually in the same classification area as fetal alcohol syndrome. Exposure to environmental toxins such as lead, mercury, other heavy metals, and then in utero infections such as rubella, cytomegalovirus, and toxoplasmosis also put a child at risk. So I remember toxoplasmosis when we had a cat inside. We don't anymore, but my previous 2 pregnancies, I could not change the litter box. That duty was shifted to my husband because of the risk of toxoplasmosis. And that's something so simple, but you had to be educated about to know that that was something that puts you at risk for prenatal infection. So there's a lot of risk factors there. All right, so prematurity and low birth weight. Prematurity is birth prior to 37 weeks gestation with low birth weight, which is less than 5.5 pounds. Very low birth weight is considered less than 3.3 pounds. Premature infants are more susceptible to illnesses that produce developmental disabilities. Many have respiratory distress that they might need to be intubated. They may need a long-term tracheostomy because of their particular needs when they're born. They don't have that, and a lot of times the respiratory distress, their lungs haven't developed, and they have to get steroids at birth to help develop their lungs, to help them get to the point where they need to be to breathe on their own independently. The book talks about they may suffer noise-induced hearing loss because within that NICU environment, I don't know if you've ever been in there, it could be a very loud environment. There are a lot of machines, the breathing machine keeping the baby alive. They're in that tube. You can only touch them with their hand through the gloved area, so they're not being exposed to a lot of the germs within the air itself because they're so fragile. And so that's a risk for them, the noise-induced hearing loss. Intubation could cause oral defensiveness or aversion or trauma or damage to the larynx. So they get intubated, they could have vocal fold damage that we're not aware of until later on when that vocal development is there. They could have aversion to anything in their mouth because think about it, that's the first thing you experience within your mouth of coming from this nice, warm, comfortable environment of mom's belly to out in the world. If that's not shocking enough, hey, let's take a tube down your throat to save your life. You're not going to want things in your mouth. I mean, that's just the way that we work as humans. So that can be something that we need to work with those infants and trying to lessen that oral defensiveness or aversion to nipples and for feeding purposes. The parents may be less willing to hold, handle, and play with the child because of the perceived weakness, sickness, and fragility of the child. I mean, these are very fragile babies, and you're scared to hold an infant as it is when they come in, much less one that weighs 5 pounds and just seems so fragile within your hands. But we know that they're not fragile, and I can tell you that, especially after 3, they can handle a lot more than what we think they can. But it's just that first child, especially, and then or a child with special needs, you just worry so much about what can hurt them because we are very hyper aware of their fragility within that state. So their first hurdle, these premature infants, is to survive, just survive life. We know that the smaller the weight equals the higher mortality rate, but we've also seen those mortality rates decrease as the technology has progressed. So we have infants surviving at 24 and 25 weeks gestation being born that would not have survived 20 years ago. And so that's great that our medical advances have allowed these infants to survive and given their mortality, given the mortality rate such a lower number. So we need to keep in mind too, though, that the support systems these infants need might be higher if they're the earlier that they're born and the less that they weigh. So that's something for us to consider. 50% of premature infants are at risk for developmental delays. So half of them that are born premature will have a developmental delay of some sort. And then early intervention has the greatest effects on infants whose mothers had less than a high school education. So again, those parents, as we talked about the resources that are available, the parents with less resources probably need the most support because that provides the greatest effects on the benefits versus the parents who are very knowledgeable. My friends who had the child at 32 weeks, 33 weeks gestation, they were very educated. They were talking to me as their SLP friend about what they should be looking for within their child. They were utilizing their resources. They had that because they were college-educated individuals. So, but we can look at this and say that that small investment in early intervention can have important effects for children at risk due to prematurity and low birth weight. long-term effects. We're saving money essentially by providing the service earlier because those children will need less support as they grow older. So other high-risk factors besides prematurity and low birth weight, we have genetic and congenital disorders, any kind of inborn errors of metabolism such as Hurler syndrome, Hunter syndrome, and Morquio syndrome. I'm not sure if I'm saying that right. Any type of craniofacial disorders, which have adverse effects on morphology and auditory mechanism, congenital forms of deafness, and then, of course, chromosomal abnormalities like Down syndrome, trisomy 21, three members of chromosome 21, Creutzfeldt syndrome, disorders of the sex, X and Y. It mentions Klinefelter syndrome. I actually have a student with Klinefelter syndrome at my school. Turner syndrome, Fragile X syndrome. I've had Fragile X syndrome students. I've had Klinefelter syndrome. I've had Williams syndrome, and I've had Down syndrome in my 13-year career as an SLP. So don't think that these are isolated syndromes. That, oh, you're never going to see that. You will. I mean, I wouldn't think I would have seen all of those in 13 years. And I'd never even heard of Klinefelter syndrome until 4 years ago when the student walked into my door. So they're definitely out there, and you will have that experience within your career as an SLP at some point or another, especially if you work with children. Other risks identified after the newborn period. So those are the risks that we know when they're born, how to identify them. After the newborn period, hearing impairment may not be identified at birth, but many states, Mississippi included, provide newborn hearing screenings. In fact, Mississippi was one of the first states in the nation in the 1980s to provide hearing screenings for all newborns. That's one thing that we do really, really well in our state, is identify those students with hearing impairments at birth. But if they do not have that infant hearing screening, remember from last semester we learned it's usually age 3 when they're identified with that hearing loss, because what happens at age 3, age 2, 3, they're not talking, they're not putting together words, they get referred for a speech language assessment. First thing that you assess is hearing to ensure that they hear, and lo and behold, they have a hearing loss that wasn't identified at birth. So it might lose those 2 or 3 years of services that could have been received if you didn't identify that hearing loss at birth, but sometimes you just can't help it because the ABR that's done within the hospital setting may not be the most refined hearing test that we have to identify all types of hearing loss. That's just the brain response hearing test versus the full audiometric assessment that we get when we refer somebody to an audiologist. Then we have disorders without physical stigmata, such as autism, intellectual disabilities, specific language disorders that are not identified until the prelinguistic or emerging language period. And then children who experience abuse and neglect are often identified after the newborn birth period. Of course, we can identify the ones that were fetal alcohol syndrome or drug abuse. We'll identify them usually as a potential abuse or neglect candidates because of the nature of the mother's abuse within that gestational period. But other than that, we're not going to be able to know leaving the hospital if a child's going to be at risk for abuse or neglect, unfortunately, until they've had some time to develop and go home with those parents and to have that experience. And that will complete this week's module for early intervention and high-risk infants.